Hello everyone. So today's topic is acoustic neuroma, or also known as vestibular schwannoma. Now this is a benign and a locally invasive tumor and the most common benign tumor of cerebropontine angle. But being benign, though it is benign, still it is non-capsulated, contrary to most of the benign tumors, and it is extremely slow growing tumor. It is most commonly seen in elderly peoples around 40 to 70 years of age. And the most common site of origin of our acoustic neuroma is the inferior vestibular nerve. Okay, and the site from where this originates is the junction of the peripheral myelin and the central myelin, and this junction where the peripheral myelin is formed from the central myelin is known as Obersteiner Rutledge zone, that is located while it is transversing through the internal acoustic meatus. So this condition is most commonly found in elderly, but in cases it is seen in young young or adolescent, we should think of a child who has neurofibromatosis. Now if there is a adolescent who comes with acoustic neuroma and that is bilateral, we should suspect neurofibromatosis type 2, and if it is unilateral, it may be neurofibromatosis type 1. The presenting features start from the location, means the inferior vestibular nerve is first affected at the site while it is transversing through our internal acoustic meatus. Now this is our internal acoustic meatus, this is the falciform crest, and this is the Brill's bar separating the four nerves. This is the superior vestibular and inferior vestibular nerve facial nerve lying in the anterior superior part of the internal acoustic meatus. So this will be our petrous bone, okay, like this of the right side. Anterior superiorly will be the facial nerve, inferiorly the cochlear nerve. Now this inferior vestibular nerve is the first to get affected, and the nerves surrounding it due to the tumor will be first affected. Okay, so when inferior vestibular nerve grows, the first nerve to get involved will be cochlear nerve, and this will lead to a retrocochlear type of hearing loss, that is sensory neural hearing loss. Since this tumor is extremely slow growing, okay, so in most of the cases this sensory neural hearing loss will be very slowly progressing, and sensory neural hearing loss will be accompanied by tinnitus. In some cases where cystic changes or hemorrhage has occurred, this sensory neural hearing loss will be profound and will be sudden. Okay, and next is the involvement of superior vestibular nerve. Now when this tumor from inferior vestibular nerve grows, it erodes the bone and involves the superior vestibular nerve. Now we should remember that when superior vestibular nerve is involved, there is no vertigo. Now this is because the growth of this tumor is really very slow. So when superior vestibular nerve of one side gets starting involved, the other side of superior vestibular nerve and the central CNS connection compensate for this loss from one side. So finally we have no effect on our balance, though there may be mild dizziness, but there will be no serious vertigo until and unless as there was a sudden sensory neural hearing loss in a limited number of cases who had hemorrhage and cyst. Here also some patients who may have hemorrhage or cyst in the place may have a severe and acute attack of vertigo. Otherwise, due to central compensation and slow growth of tumor, there is no vertigo. Another thing we need to remember is that the facial nerve may get involved, but since the main part of facial nerve is motor and sensory part is affected first in the case of tumor growing and compressing on nerve, and later is the motor part affected, so most of the facial nerve and the areas it supply through its motor route is not going to get affected, but the smaller part of facial nerve, that is sensory, that is nerve of that is the nervous intermediates of nerve or wrist bug, that might get affected soon, and this will lead to a characteristic sign that is though not that much important, that is Hitzelberger sign, because it is only seen in less than 25% of cases, so it is clinically insignificant. Now in Hitzelberger sign we see a hypoesthesia over the posterior superior part of our external auditory canal. This is a small part of external auditory canal that is being supplied by our sensory part of the facial nerve. So this will get hypoesthesia. Okay, so these were some signs initially when internal acoustic meatus is involved. Now since the tumor is growing slowly but it will progress, the tumor will grow out of the internal acoustic meatus and it grows towards the cerebellopontine angle, as you are seeing in this image. So the tumor starts growing and it compresses the structures nearby. As you are seeing in this image, it compresses posteriorly on the cerebellum, and its upper and lower pole respectively involve these nerves. So the upper pole involves the nerves that are passing near to the petrous apex. These are the fifth nerve, the trigeminal nerve, and this leads to a characteristic sign, and the first sign that is seen in the case of acoustic neuroma. This is the loss of corneal reflex. Okay, so after the involvement of the eighth nerve, that is vestibular nerve, this is the second nerve to get involved. Okay, so the earliest nerve involved is eighth nerve, followed by the fifth cranial nerve. Now another thing upper pole leads to is the involvement of sixth nerve that is passing near to the petrous apex through the canal, and this leads to diplopia. The lower pole involvement leads to the compression of nerve that are passing through the jugular foramen, that is the ninth, 10th and 11th cranial nerve. So the thing we need to remember is that initially the caloric test will be normal. This is because through caloric test we are testing the lateral semicircular canal. Okay, so in the medial wall of middle ear is the lateral semicircular canal bulge. So we are testing only lateral semicircular canal, but lateral semicircular canal is supplied by superior vestibular nerve, which is involved in the later part of the disease progression. So initially the caloric test will be normal. Later, when superior vestibular nerve is involved, the caloric test will be reduced. So this is the thing we need to remember. So the presenting feature in this case were unilateral sensory neural hearing loss in a patient who is around 40 to 70 years of age, and he will also have tinnitus. And the later progression will, the patient will present with characteristic signs of the cranial nerve involvement. And the first ocular sign that we see is the loss of corneal reflex. The next thing we will try to understand is the investigations that lead us to the diagnosis of acoustic neuroma. So Rene's in this case will be positive, since this is a sensory neural hearing loss. Weber's will lateralize to the better ear, and ABC and the Schaubeck will be obviously shortened. The audiometric test will not show any AB gap, suggesting it is a sensory neural hearing loss. Stapedial reflex is present. One more thing, the speech discrimination score will be really very poor. This is because of it is a sensory neural hearing loss, and in this case we see a rollover phenomena due to nerve fatigue. The best audiometric test for the diagnosis of acoustic neuroma is BERA, and in BERA the two characteristic sign and the most common one is the interoral latency of the second wave that is seen in the case of BERA of more than 0.2 millisecond. And this is the characteristic sign seen in the BERA. Another thing is increased latency between the first and the fifth wave. So these are the two signs seen in the case of BERA. But the gold standard investigation here is gadolinium enhanced MRI. As you are seeing in this image, we see a characteristic sign that is ice cream cone appearance. Okay, so this is what we needed to remember about acoustic neuroma. Thanks for watching.